This conference will now be recorded.
Start.
ఓకే ఎస్కలేట్ చేసేసి క్లోజ్ చేసాడు నువ్వు వస్తావా 11:30 సరే అంతవరకు ఇలాగే ఉంటుంది నేను కనిపిస్తాను అన్న వాళ్ళకి మరి ఇది ల్యాప్టాప్ స్క్రీన్
అన్ని కనబడుతుంది
స్క్రీన్ కనిపిస్తుంది సరే Good morning, students. I am Dr. Ramamurthy, joining you in the online class first time. Good morning, everybody. Now I am continuing the liver diseases of the liver, which I have left in the month of I think March. So it is halfway I have left diseases of the liver, and most of it completed except the cirrhosis and biliary diseases. So I will start with the cirrhosis. The objective is definition, classification, pathogenesis, morphology, clinical features, complications. So I will discuss in detail the complications of cirrhosis, portal hypertension, ascites, and hepatic failure. So first begin with the cirrhosis of the liver. Cirrhosis is end-stage liver disease characterized by disruption of liver architecture by fibrotic bands that divide the liver into nodules of regenerating liver parenchyma. It is diffuse process resulting from widespread parenchymal necrosis, and the condition is generally irreversible. So cirrhosis is end-stage liver disease. End-stage liver disease. So many conditions ultimately progress to cirrhosis. So among them, most important is alcoholic hepatitis, viral hepatitis, some drug-induced hepatitis, autoimmune hepatitis. So various conditions. Most importantly, alcoholic hepatitis progresses to cirrhosis. So in cirrhosis, by definition, it is a diffuse process involving the entire liver, and it is characterized by loss of liver architecture by fibrous bands, and these bands surround the regenerating liver nodules. So that is the definition of cirrhosis. There are many classifications of cirrhosis. One is etiological classification, that is most important, and the etiological causes of cirrhosis. Most important cause for cirrhosis is alcoholic liver disease. Alcoholic liver disease comprises fatty change, fatty liver, alcoholic hepatitis, and alcoholic cirrhosis. So there is 60 to 70% of cases of cirrhosis are due to alcohol abuse, chronic alcoholism. And non-alcoholic fatty liver disease also occurs particularly in association with metabolic disorders, obesity, diabetes mellitus, dyslipidemia, and other conditions. And previously, most of these cases are kept under the last category, that is cryptogenic cirrhosis. And the next about 5 to 10% of cases of cirrhosis are caused by chronic viral hepatitis, autoimmune hepatitis, and sometimes drug-induced hepatitis. So, and biliary cirrhosis accounts for about 5% of cases. Less common, extrabiliary obstruction or primary biliary cirrhosis or primary sclerosing cholangitis, and rare metabolic disorders also end up in cirrhosis. Those conditions are hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, and other conditions. So in this class, we discuss mainly about the clinical manifestations, gross and microscopic appearance of cirrhosis, clinical manifestations, and consequences of cirrhosis, complications of cirrhosis, and also we discuss some hereditary conditions which progress to cirrhosis. There are hemochromatosis, Wilson's disease, and alpha-1 antitrypsin deficiency. So another classification, not so important, is morphological classification. Morphological classification is based on the appearance, gross appearance of the liver. So liver is replaced by nodules, regenerating nodules. Depending on the size of the nodules, you can classify cirrhosis into micronodular cirrhosis and macronodular cirrhosis. Micronodular, if the size of the nodule is less than 3 millimeters, and macronodular cirrhosis when the size of the nodule is more than 3 millimeters in diameter. And some cases are mixed. Micronodules are present as well as macronodules are also present. Sorry, micro and macro. So come mixed category. Normally, the liver architecture is diffusely replaced by normal liver architecture is diffusely replaced by nodules of regenerating liver cells separated by bands of collagenous fibrosis. So that is the main structural change in the liver of cirrhosis. Initially, the fibrous septa are thin and delicate. They extend through sinusoids from central vein to portal regions and from portal region to portal region. Later, as the disease advances, the fibrous tissue becomes thick. Broad bands of fibrous tissue surround the entrapped parenchymal nodules, parenchymal hepatocytes, which form the nodules, and fibrous bands become thick and broad. And there is also some associated inflammation because of liver cell necrosis. So this is the early stage histological feature of cirrhosis. In the early stage, particularly from the appearance, you can say this is alcoholic cirrhosis because the liver cells show vacuolation of the cytoplasm. Vacuolation of the clear colorless vacuoles are seen in the cytoplasm of the hepatocytes. So from this, you can say it is a steatosis, alcoholic liver disease, which is beginning in the beginning. It is in the beginning. So in the beginning, you will see blue-colored collagenous fibrous tissue, which is stained by trichrome stain. So blue thin strands of fibrous tissue surround the large central vein and extend peripherally to the portal area. The portal area is not shown here, but the bluish bands of connective tissue or fibrous tissue surrounding the sinusoids and also the liver cells. So this is the earliest stage or the initial stage of liver cirrhosis. In the late stage, you can see here the surviving hepatocytes regenerate, they proliferate and form rounded circumscribed nodules. Small nodules or large nodules, micronodular or macronodular, small or large nodules, which are surrounded by thick fibrous bands. Fibrous tissue is stained blue by trichrome stain. So bluish bands of fibrous tissue surround the regenerating nodules. So thus the lobular architecture of the liver is disturbed. It is lost. Now in the beginning, you can see this illustration where the blue colored area represents sinusoidal lumen, blood. sinusoids are lined by hepatic sinusoids are lined by endothelial cells, and there is a space between endothelial cells and hepatic cells. In that space, you will find a quiescent stellate cell, which normally stores vitamin A. So those vesicles are vitamin A. That function of etho cells or stellate cells is synthesis and storage of vitamin A. But in cirrhosis, they are the source of fibrous tissue, fibrosis. They lay down collagen, and they are stimulated by various cytokines produced by Kupffer cells and inflammatory cells, and they become transformed into myofibroblasts, and they lay down collagen. So the collagen synthesis and laying down extracellular matrix synthesis and deposition begins in the sinusoidal space, and it is done by transformed stellate cells or etho cells. So that is about pathogenesis of cirrhosis of the liver. So we discuss here now the morphological appearance of various types of cirrhosis, gross, color, and appearance of various types of cirrhosis. The causes of cirrhosis. Causes I have already mentioned. In the etiological classification, most important cause for cirrhosis is alcoholic hepatitis, chronic alcoholism. Next important, viral hepatitis and other types of cirrhosis, biliary cirrhosis and other types of cirrhosis. That is already done, but some more lesser common causes of cirrhosis will be discussed. We also will discuss the clinical effects, clinical manifestations, and consequences and complications of cirrhosis. Morphology of liver in cirrhosis. We see the gross appearance of liver in gross appearance of liver in cirrhosis. So this is the alcoholic cirrhosis. You can see here the real picture. The liver is enlarged and shows a yellowish appearance. On close inspection, you can see small uniform nodules. So it is micronodular cirrhosis in case of alcoholic cirrhosis. The nodules are less than 3 millimeters in diameter. So the liver is enlarged and yellowish because of alcoholic hepatitis or alcoholic pathology. And you define brands of. So this is the alcoholic cirrhosis where liver is grossly yellowish and micronodular. This is a cirrhosis due to viral hepatitis B and C. So in chronic hepatitis which progresses to cirrhosis, that is called post-hepatic cirrhosis or post-necrotic cirrhosis. Here you will see enlarged liver, both large right lobe and small left lobe both are seen in this picture, and you will see liver is replaced by multiple large nodules more than 1 centimeter in diameter. So it is macronodular cirrhosis. What is the color? Color is brownish color. What is the color of this cirrhotic liver? It is greenish because of a biliary obstruction. Chronic biliary obstruction occurs in primary biliary cirrhosis. So liver is greenish and replaced by small nodules, micronodular cirrhosis. So a sagittal section through the liver demonstrates nodularity and bile staining of the parenchyma. What is the color of this cirrhotic liver? This is dark colored, dark brown color. This is also called pigment cirrhosis. Cirrhosis due to hemochromatosis. Hemochromatosis is a condition, hereditary condition, where there is abnormal excessive accumulation of iron in parenchymal tissues. parenchymal organs like liver, pancreas, heart, and skin. So this is also called pigment cirrhosis, and the dark pigment is because of accumulation of iron. The liver is enlarged, and most of the nodules, most of the surface shows small nodules, micronodular cirrhosis. Remember, cirrhosis is a predisposing factor for hepatocellular carcinoma, cancer of the liver cells. So, most important complication of cirrhosis is development of cancer of liver, parenchymal malignancy. So, cancer, hepatocellular carcinoma arises from the hepatocytes. Some of the regenerating nodules become malignant, and here in this case of hemochromatosis, you can see the small nodules in the background, brownish colored liver. In the center you will find a large irregular mass, which is cancer of the liver. So hepatocellular carcinoma is a complication of many cirrhotic livers, particularly in hemochromatosis. So this cut section shows, in addition to cirrhosis, you will find a tumor, hepatocellular carcinoma. So iron is also deposited in the pancreas. Here pancreas also is discolored. It appears dark, and because of deposition of iron in the acinar cells and in the parenchyma, connective tissue, dark color or red color of the pancreas is due to deposition of iron. And diabetes is a complication of hemochromatosis because of destruction of beta cells which synthesize and secrete insulin. So cut section of microscopic examination of liver in hemochromatosis, you will find the star shows a hepatic nodule, regenerating nodule. The cytoplasm of the liver cells show brownish iron. Iron is also deposited in the fibrous tissue. The arrow indicates the bile duct. There is mild bile duct proliferation in cirrhosis. And iron can be demonstrated by using Pearl's Prussian blue. Pearl's iron stains iron blue. So iron granules appear blue and stained with Pearl's iron, ferrocyanide. So hemochromatosis is a hereditary condition caused by mutation on chromosome number 6, which encodes a protein called HFE protein. And this HFE protein normally regulates iron absorption. Because of this mutation, there is excessive absorption of iron from the intestine. Excessive absorption of iron from the intestine. And in homozygous type, also disease develops in homozygous type. And excess of iron is deposited in the parenchymal cells of pancreas and islets, leading to diabetes mellitus. In the myocardium, leading to cardiac failure. In the liver, stimulates fibrosis, leading to cirrhosis. So these three organs. In addition, you can also see iron deposited in the skin. In the skin, iron is deposited mainly in the sweat glands. Excessive melanin production is also seen, which explains the term bronzed diabetes. The diabetes in hemochromatosis is described as bronzed diabetes. That means diabetes with dark skin, bronzed diabetes. So iron accumulation also occurs in some conditions where patient may take excess of iron parenterally or orally, or he may receive repeated blood transfusions, particularly patients with sickle cell anemia, aplastic anemia, and thalassemia. These patients require multiple transfusions, and therefore they also are at risk of developing cirrhosis because of iron accumulation. Another condition, hereditary condition where cirrhosis develops is Wilson's disease. Wilson's disease, also called hepatolenticular degeneration, it is a rare autosomal recessive condition due to mutation of ATP7B gene on chromosome number 13, which encodes a copper transporting enzyme. So this is characterized by accumulation of copper in the liver. Normally, copper is absorbed from the intestine, and it is bound to a plasma a protein that is called hepatocellular, and then combined with a ceruloplasmin, it is secreted into the blood. It is carried in the blood bound to ceruloplasmin, a copper binding protein. So this protein is not synthesized because of genetic defect. Therefore, iron accumulates in the liver. It also accumulates in the brain, basal ganglia, and also in the cornea. So that forms a Kayser-Fleischer ring. So serum levels of ceruloplasmin are reduced, and liver shows acute hepatitis, chronic hepatitis, and sometimes cirrhosis. So this is the histological section of liver, which shows copper. Copper is demonstrated by rhodamine stain. Red granules of copper can be demonstrated by rhodamine stain. Here you can see the picture of eye, which shows a brownish limb, a brownish discoloration in the lower part of the limbus. That is due to deposition of copper in the decimates membrane close to the limbus. So you can see brownish deposit at the periphery of the iris close to the limbus, which is called Kayser-Fleischer ring. This is a diagnostic of Wilson's disease. Now there is another condition which may lead to cirrhosis, that is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is a protease inhibitor which inhibits excessive action of neutrophil elastases, proteases, and other enzymes which generally leak out into the surrounding tissue from inflammatory cells in case of inflammation, and also cigarette smoking. So a cigarette smoke irritates and stimulates infiltration by neutrophils. Neutrophils become activated. They secrete various proteolytic enzymes into the surroundings. But excessive damage from these inflammatory cells through proteases is inhibited by antiprotease, that is alpha-1 antitrypsin. So this protein beta 2 globulin is synthesized or encoded by a gene that is called PIM, that is normal. A mutation, that is PIS, is associated with mildly decreased activity, but PIZ is shows markedly decreased activity. If both alleles are Z, PIZZ, for example, that is homozygous state. In homozygous state, PIZZ, there is marked deficiency of antitrypsin. So this inhibition of protease activity is lost. That leads to destruction of the tissue in inflammatory sites, particularly in smokers in the lung. The destruction progresses without inhibition, and that leads to emphysema. And within the liver, I will tell you. So antitrypsin, also alpha-1 antitrypsin functions as protease inhibitor, regulating the functions of proteases, particularly neutrophil proteases, but they also inhibit trypsin, chymotrypsin, and bacterial proteases. Normally, inflammation causes considerable damage to this normal tissues in the surrounding tissues, and in the absence of this regulatory function, it is excessive damage to the tissues. So the clinical presentation is the basic pathology is lack of alpha-1 antitrypsin in the serum, in the blood and body fluids. So this protein, alpha-1 antitrypsin protein, is synthesized in the liver, but it is a misfolded protein. Misfolded protein means it is not secreted into the blood, it is retained in the liver. This misfolded protein is toxic to the liver cells. So you will see the pathology in the liver because of retention of this abnormal misfolded protein within the liver cells, and not lack of availability of this protein, inhibitory protein, particularly in smokers in the lungs, leads to emphysema. So these are the two pathological conditions associated with alpha-1 antitrypsin deficiency. One is cirrhosis in the liver, another is emphysematous change in the lungs, pan-acinar emphysema. The clinical presentation is patients develop micronodular cirrhosis and are at increased risk for hepatocellular carcinoma also. Cirrhosis in general predisposes to hepatocellular carcinoma. Please remember, the regenerative nodules, the regenerative activity or proliferative activity of liver cells is accumulates frequently mutations, various mutations. The mutations, if they become permanent, they may result in malignant transformation of the hepatocytes, leading to development of carcinoma. So same thing happens here. And patients also develop chronic obstructive pulmonary disease, that is emphysema, particularly in smokers. In the liver, this is the section of liver, shows enlarged hepatocytes, and hepatocyte cytoplasm accumulates eosinophilic globular masses of varying size. So they are PAS positive, cytoplasmic globules or granules. So this is the protein that accumulates in the liver cells. That is abnormal protein, misfolded protein that is not secreted into the blood or body fluids. It is retained in the liver cells, and within the liver cells they cause liver cell injury leading to cirrhosis. So clinical manifestation, that's we have discussed almost all important causes of cirrhosis. And the previous classes I told you in detail the alcoholic cirrhosis, post-hepatic cirrhosis, or viral cirrhosis due to viral hepatitis and other things. In this class I have completed the minor causes of cirrhosis. Now we discuss the clinical consequences of cirrhosis in general. Cirrhosis may be asymptomatic, no symptoms until advanced, and it lead to progressive liver failure and death. If 80 to 90% of liver is damaged, then it may lead to liver failure, manifestations of liver failure. And mortality rate is high. Liver failure in 70 to 95% of cases leads to death. The onset of disease is insidious. Most of these conditions are chronic, which predispose to cirrhosis. They are not acute conditions, they are chronic conditions. And the symptoms may be non-specific, like weakness, fatigability, weight loss, anorexia, loss of appetite, muscle wasting, and low-grade fever due to hepatocellular necrosis, and some latent infection may be present. So all these are non-specific symptoms. Advanced cases may develop a number of complications. So complications, all these are complications of cirrhosis. Portal hypertension, progressive hepatic failure, hepatocellular necrosis, carcinoma, chronic relapsing pancreatitis, steatoria, gallstones, infections, hematological derangements, that is called coagulopathy, cardiovascular complications, musculoskeletal abnormalities, endocrine disorders, hepatorenal syndrome, hepatopulmonary syndrome. So there are so many consequences or complications of cirrhosis. Most important are the first three: portal hypertension, progressive hepatic failure, and hepatocellular carcinoma. We will discuss in detail these three conditions, and others will be discussed in several other occasions. So portal hypertension. What is portal hypertension? The portal pressure, just like systemic venous pressure, there is some amount of pressure within the portal circulation. The normal pressure is 5 to 10 millimeters of mercury, average 7 millimeters. We call portal hypertension when the pressure, portal venous pressure, exceeds 10 millimeters of mercury. Generally, in most of the cases, you will find 20 or 30 or 40 millimeters of mercury. So the portal system drains venous blood from gastrointestinal tract to the liver. It comprises portal vein and its tributaries, that is splenic vein, mesenteric veins, and gastric veins. So portal hypertension, the rise of portal pressure may occur. This is the liver. The rise of portal pressure can occur before the portal vein enters into the liver due to obstruction. Suppose that is arrow is there, portal hepatic, prehepatic, portal vein is thrombosed. So there is portal hypertension, but it will not affect the liver. It will not affect the liver. The obstruction may be within the liver. That is intrahepatic portal obstruction. So within the liver, you will find cirrhosis, cirrhotic nodules, fibrous tissue, compresses the portal venous radicals, and there is also abnormal connections between the hepatic artery and the portal vein within the liver. In these conditions, most important cause of intrahepatic portal hypertension is cirrhosis. Other causes are schistosomiasis, sarcoidosis, and multiple secondaries in the liver. All these cause portal hypertension, intrahepatic portal hypertension. The obstruction to the flow of portal blood may be beyond the liver. That may cause a post-hepatic obstruction. So hepatic venous blood drains into inferior vena cava. So beyond the liver, there may be thrombosis again that obstructs the flow, portal blood flow. So post-hepatic causes of portal hypertension are hepatic venous outflow obstruction due to Budd-Chiari syndrome, usually due to thrombosis of the hepatic vein. There is that is pictured there. Hepatic vein is shown, and there is a thrombosis of the hepatic vein. or it may also be caused by thrombosis of the inferior vena cava also. And so there are many conditions which may produce portal hypertension. They are classified into intrahepatic, post-hepatic, and pre-hepatic. And we are interested in the portal hypertension caused by cirrhosis. What are the mechanisms? What are the consequences? Increased intrahepatic resistance to blood flow through the liver in cirrhosis is due to many causes. One is deposition of fibrous tissue. Fibrous tissue is mainly deposited in the portal area. There is bridging fibrosis, that is portal to portal, portal to central vein. There is bridging fibrosis. Fibrous tissue compresses the vessels, portal veins, and compression is also by regenerative nodules. And because of these two things, the blood flow is sluggish and abnormal. There are abnormal connections or shunts between hepatic arterial branches and portal venous tributaries. What happens when the hepatic arterial branches are connected with the portal venous tributaries? Arterial branches, hepatic arterial blood is high pressure system. The pressure is higher in arterial blood than in the venous blood. So the high pressure is transmitted to portal veins. So there is portal hypertension because of abnormal connections. And there is also vasoconstriction due to deficiency of nitric oxide and increased production of vasoconstrictor, that is endothelin. And in general, there is hyperdynamic circulation that adds to portal hypertension. So that is the pathogenesis of portal hypertension. Now, what are the consequences? So what happens? What are the consequences of portal hypertension? This raised pressure is transmitted back to the tributaries which join the portal vein to join the main portal vein. So tributaries are from the spleen, tributaries are from the gastric veins, gastric tributaries, and also mesenteric veins. All these join to form portal vein. So the high pressure generated within the liver is transmitted back to the other veins. So as a result, you will find abnormal connections between the portal venous radicals and the systemic veins. They are normally, you can see in this picture, the junction of esophagus and stomach, gastroesophageal junction. You can see development of varices, dilated veins develop because of raised portal pressure. Normally, these veins remain collapsed. There is no circulation normally, but because of raised pressure, they become opened up, and the varices develop submucosally at gastroesophageal junction, and also at the lower end of the GIT in the rectum, where the rectal veins join and form anastomosis with the systemic veins. So dilatation of these anastomotic vessels lead to development of hemorrhoids that may cause bleeding per rectum, and spleen drains to portal vein through splenic vein. So rise in pressure, splenic vein venous pressure leads to splenomegaly, congestive splenomegaly. Spleen is enlarged. What happens is when the spleen is enlarged, what do you call it? Hypersplenism. The normal function of the spleen is destruction of senescent red cells, leukocytes, and thrombocytes, platelets. So enlarged spleen is hyperfunctional. Hyperfunctional spleen prematurely destroys red cells, leading to anemia. Prematurely destroys leukocytes, leading to leukopenia. Prematurely destroys platelets, leading to thrombocytopenia. So one of the manifestations of hypersplenism is anemia, leukopenia, and thrombocytopenia, together called pancytopenia. So, and not only that, you can see here the portal vein through the ligamentum teres, I think, the band that separates liver, big lobe of the livers with small lobe, that joins systemic veins around the umbilicus, para-umbilical veins. So that they become dilated and produce what is called caput medusae. So abnormal shunting of blood from the portal vein to the systemic veins occurs at various levels. Even in the retroperitoneum, there are anastomoses. So the same thing is presented here, and there is one of the consequences of portal hypertension is development of ascites. The portal venous pressure is raised. The increased hydrostatic pressure causes accumulation of fluid in the peritoneal cavity that leads to ascites. Accumulation of fluid in the peritoneal cavity is called ascites. So raised portal pressure, hydrostatic pressure within the portal venous system pushes the fluid from the intravascular compartment to extravascular compartment, that is the peritoneal cavity. So fluid becomes detectable in the peritoneal cavity if it exceeds 500 ml. So in general, in cirrhosis, massive amounts of fluid collect in the abdominal cavity, leading to distension of abdomen. That is called ascites. Ascites is also aggravated by failure of liver to synthesize various proteins, including albumin. So hypoalbuminemia, because of liver failure, hepatocellular failure, contributes to edema and also fluid accumulation in the peritoneal cavity. And esophageal varices is potential source of hemorrhage. Clinically important because patient may cough patient may vomit blood. Hematemesis, that is called hematemesis. Hematemesis is fatal, a fatal complication. So all these are there is liver failure and the bypass of blood from the gastrointestinal tract is bypassing liver, which is already failed, and it is these metabolites which are normally detoxified in the liver, they are bypassed, they are entering into the systemic circulation, and these metabolites they are toxic. That's important. So in the cirrhosis, there is reduced protein synthesis, hypoalbuminemia, reduced oncotic pressure contributes to ascites. There is portal hypertension leads to ascites, and there is also increased lymph formation. Lymph percolates the liver, and fluid collects in the peritoneal cavity contributes to ascites. And whenever there is fluid loss into the extravascular space, there is a activation of renin-angiotensin system, and that leads to retention of sodium and water and that contributes or aggravates ascites and also edema. So this is the patient picture, shows massive ascites, and you can also see dilated veins over the abdomen, and that is because of caput medusae. Communication between portal system and systemic venous radicals will show the dilated veins on the abdomen, that is called caput medusae. And there is hepatic failure. This is a very important complication, and patients with hepatic failure manifest the various features, and I think I will stop it here. I will continue in the next class. Time is over. So today there is a little delay because of class connection, online connection with my computer. So we will start. We will continue in the next class. Thank you.